we had a clear understanding what ADT is. If we kind of call it, it's more, what she said was a classic medicine, the first group of medicines used. So now what I'm going to do is share my, so there's some key terms that I want you to understand. You heard what she said before. It's GnRH. So that's a gonadotropin releasing hormone. You heard luteinizing hormone, which was LH. We talked about novel hormone therapies. Those are those drugs like enzalutamide, apalutamide, abiraterone, darolutamide. So all of those are what you would call novel hormone therapies, right? Now, there's a term that comes up, and the reason why we bring this up is because it was de novo metastatic prostate cancer. So that may be a word you may hear either at the doctor's office or when you're talking to other people. That de novo just means new. So that means when the person was diagnosed, they already were diagnosed at stage 4. Now, what I want to talk to you about is this. Every time you hear someone say stage 4, people get a gut feeling. Is it time to get your affairs in order? And what we want to do is change that mindset, because there's a lot of treatments that are available. Another key term was metastatic hormone-sensitive prostate cancer. That's very important because that's a person who has cancer that has gone outside the prostate to other organs in the body, but it is still sensitive to an ADT. Now, that's the first classical line of treatment. Then there's a concept for treatment intensification. Now, that treatment intensification is that now that you're on an ADT, they may want to put you on another group of drugs. So it's combination, not a monotherapy or a single drug treatment by itself, but multiple ones that kind of give you a greater fighting capabilities. Neoadjuvants are given to patients before surgery to kind of help shrink the tumor. Adjuvant therapies are given to help after surgery or radiation to help kill the cancer. So these are terms that you will hear moving forward along your journey. Now, what was important? We're dealing with testosterone. We're dealing with testosterone. And testosterone influences various tissues of the body, right? Skin, male sex organs, muscle, the brain, bone marrow, and your bone. Now, what was something that was very interesting, and I'm glad she gave you a very good holistic approach at what to look for. Dr. Morgans did not just stop with the drug. She went on to the side effects. And then she started talking about what we've been talking about for the past 6 months, at least the past 3 months. Diet, exercise. And she did highlight something that was very important too, that along with taking these drugs, people get depressed. So what do we know? When we talk about prostate cancer, it's the leading cause of cancer in men of African descent. And we know that ADT is the therapy that's key, your key treatment option. We understand that it blocks male hormones. Testosterone is that male hormone. Now, you heard Dr. Morgan said it needs to drop down below 50, and that's important. And that's different than the level of your PSA. Now, so how does it work? We know androgens, and it's either testosterone or dihydrotestosterone, or DHT. What does she say? Feeds the cancer, fuels the cancer. Now, where is this testosterone, this androgen produced? The testicles, adrenal glands, prostate cells. And our objective in using ADT is to lower or block androgens, to shrink up or starve the cancer. Now, there are different ways over the past 6 to 7 months, we talked about different ways of treating prostate cancer: active surveillance, surgery and radiation, chemotherapy, immunotherapy, targeted radiotherapy, and ligand therapy, and precision medicine therapies. Today, our focus was on understanding hormonal therapy. And the first classical hormone therapy that was used was ADT. Now think about this. In the United States, between 1940 and on, up until the late 90s, castration, surgical castration was the primary approach at treating prostate cancer. So when we talk about hormonal therapy, we're going to talk about GnRH agonists and antagonists. Okay, and she talked about that, but you've heard of these drugs like Leuprolide or D-Gerlex, or a androgen receptor inhibitor like darolutamide, enzalutamide, apalutamide, and bacalutamide, and also androgen synthesis inhibitors like abiraterone. So we could either start classically with the GnRH agonist or antagonist. We can go to androgen receptor inhibitors, or we go to an androgen synthesis inhibitors. This is just another way. Did you know I simplified it? What do the following have in common? The brain, the adrenal gland, the testes, and your diet. So in the brain, there is the pituitary gland. That's what she spoke about. This is where the bulk of that first classical approach, that GnRH treatment, agonist, antagonist, that takes place in the brain. But then if you look and you understand the pathways that are causing testosterone production, you can see where drugs like abiraterone or enzalutamide are used to block cancer synthesis or binding to the receptor so we can starve the cancer. The objective here is starve the cancer. So when it's used, through her notes, alongside of radiation for high-risk localized cancer, before radiation to shrink the cancer, that's that term I use, neoadjuvant. Cancer, if the cancer returns, then you may use it as an adjuvant in addition to surgery or radiation to help control it. What did we know? These testicular antigens, these testosterone, can be controlled by either removing the testes, that's an orchiectomy, that's surgical resection, or in this case, we were using the term luteinizing hormones instead of GnRH, but they're agonists, and these are called medical castration. So there's two classical ways to do that: surgery or medically. Again, some things, for example, the agonist that you talked about, we know Lupron. So when you're thinking about you received a shot and it was a Lupron shot, that's an agonist that plays a role in regulating testosterone production from the brain. Then we have the antagonist, which also blocks the pituitary gland, that's that gland in the brain that makes this LHRH and lowers testosterone. And we know that it's Firmagon or Orgovyx, the two. Now, what was mentioned is Orgovyx, and what wasn't mentioned, she mentioned that you could take a pill, but the Orgovyx is something interesting about this, is that it is a pill, but there's some relationship about lowering the cardiovascular effect. So clinical trials are leaning towards demonstrating that there's a difference between the cardiovascular effect of an injection versus taking the pill. But again, these are topics and things that you should talk about to your doctor. Now we have that classical. We talked about classical. Now we have these anti-androgens or androgen receptor antagonists. That first generation, the key one that we want to talk about and what you've heard is bicalutamide, Casodex. And then the second generation, these novel hormone treatments, enzalutamide, apalutamide, darolutamide, just to kind of give you a few. And abiraterone is another one, but it plays another role. We knew that it blocks the synthesis. And then there's also ketoconazole, which is another drug that's used, but it has to be used with some steroids. Now, this is a complicated picture, but I put this up here for a reason. You have stage 4 disease, and look at the treatment options that are available for people that have stage 4 disease. That's metastatic hormone-sensitive prostate cancer. Now, metastatic hormone-sensitive prostate cancer, metastatic, that means that the cancer has moved outside the prostate and it's in the tissues around it. But it's sensitive, right? It's sensitive to treatment. But look at that. ADT, what happens is you take these next generations, these novel hormone therapies like abiraterone, enzalutamide, but all of them are taken in conjunction with an ADT. So whether or not you start locally, it's ADT and radiation. Here's non-metastatic, or you have recurrent, it comes back. There's still ADT or an observation, depending on this. And whether it's metastatic hormone-sensitive prostate cancer or non-metastatic castration-resistant prostate cancer, you're still taking ADT, the classic, with the new next generation treatments. Now, I flagged this is because people are starting to do studies, clinical trials on what happens if we take away that ADT and we just use the novel. And so that's where research is going, and we'll talk a little bit later. So again, when we're talking about testosterone, these are the tissues, the skin, the brain, sex organs, bone, bone marrow, and muscle are affected. She talked about some key things that were important, the possible side effects of ADT, and just to repeat, and this is why sometimes speaking with a therapist and being able to speak candidly with your loved one about how you're feeling and what you're experiencing, because it may have reduced sexual desire, erectile dysfunction. We already learned today. Now, who knew that we had estrogen and that our drop in our estrogens, if we treat it with an ADT, causes hot flash? So that's new. So once you understand why, then you can start looking at treatments. And what Dr. Morgans didn't say was even there are people that maybe online now who are getting treatment at the Dana-Farber, and they're trying acupuncture. You see? So what we want you to understand is this. There is a treasure chest of treatment options that are available, and not to give up. The next one is depression. And she clearly showed you research that with these treatment options and with prostate cancer, people get depressed. And then you add on ADT and that drop in estrogen. Then there's that hot flash, more emotional component. And a lot of prostate cancer survivors hide that. It's time to recognize that that's part of the treatment and you can talk about it. And there was something else that was very interesting too about this blood pressure, diabetes, stroke, and heart attack. Now I bring this up because if you look at it, I mean, between high blood pressure and diabetes, people of African descent, Black people, poor folks, they're going to be at higher risk So it's going to be very important that what we've talked about before, diet, plant-based diet, Mediterranean diet, and exercise are going to be important. And lastly, some of the current issues and research is going on. Now, what's going to be important is this. They're doing research to see whether or not you can have comparing continuous therapy. That's my secondary. So in this case, if I was taking enzalutamide and an ADT, but in this case, there's a clinical trial that was using apalutamide. Okay. And so, and this is a clinical trial called Libertas. So there's something that already exists. And if you want to take a look at that, and what they do in this clinical trial is this, is a group is continuously taking it, meaning ADT plus apalutamide, and then, or it's intermittent. So they'll take a break or a holiday. And then also, we have to look at, and we presented this earlier, combining treatments, combining these novel therapies have shown to be improve the overall survival for Black men compared to the general population. So that's going to be very important for us. So in my summary, one, ADT is crucial in managing prostate cancer. And along your prostate cancer journey, ADT is a critical point along that line, from whether or not you were diagnosed with high-risk disease down to being diagnosed with metastatic hormone-sensitive prostate cancer and resistant. So we know that there's various methods of ADT. Orchiectomy surgery is in the past. Now we're looking at those drugs like LHRH that suppress it. We know that there's side effects that are associated with it, sexual function, bone density. We have to worry about our mental health. And I was very happy that Dr. Morgan spoke about your bone health, because if you fracture one time, you're more likely to get a fracture. And men do suffer from osteoporosis and not have prostate cancer. So with the ADTs, it increases your chances of developing prostate cancer. So do we have any questions? Gary, do you have anything that you see on your end?
So I have a question about ADT. Is ADT indicated for 3+4 Gleason or for more advanced cases?
Now repeat that again.
Is ADT indicated for 3+4 Gleason or for more advanced cases?
So is ADT, so the person has a 3+4
Gleason's.
But again, in this case, we're talking about intermediate disease. And so in this case, we would refer you back to your doctor. But what we are saying is this: in the more high-risk disease, ADT may be incorporated, or they may add it along with whatever procedure. So if you had radiation plus your diagnosis, or if you had surgery, depending on what's your doctor's choice. And matter of fact, it's important, and that's a good question, because I'm redirecting it back to the doctor. After you had all this information, now you can sit down and talk with their healthcare provider about you're sharing in the decision. What's going to be important for you? Do you want it? ADT. Next question.
Are there any diet recommendations while on ADT?
Well, one thing that we can say is this: when we talk about diet, in our past episodes of managing, we focused on plant-based diets, right? And we focused on regular, vigorous exercise. So in our last month's discussion, it's either kind of a Mediterranean diet or a true plant-based diet. Or like me, I'm flexitarian, so I'll get some salmon once in a while. But the point is, that's the diet that we need to shift to. And that was clearly stated, the types of diets that we need to shift to that was stated last month. Next question.
Is ADT permanent or periodic?
So in this case, ADT is continuous. Because we showed this slide, which was very important. Sorry. This slide was very important because if you look, whether it's localized disease, advanced prostate cancer, so the earlier person, if you have advanced prostate cancer, then the possibility of introducing ADT is there. Or if you have metastatic castration-resistant prostate cancer, ADT is being used in conjunction with these next generation therapies. And this is, I think it was very important that somebody brought this up again so I can show you this image. Look at what's available at stage 4 disease. That's a lot. And so that's why we want people to be hopeful and be positive about their journey, because there are treatment options that are out there, and we haven't even talked about clinical trials. Is there another question, Jerry?
At what point are you required to start the ADT treatment?
Again, when we start talking about ADT and starting treatment, we can go back to your doctor. Now, but what's important is this. You have to talk with your team. Your team isn't one doctor. It's the urologist, the medical oncologist, and the radiation oncologist. So I put that question back to you so you're empowered after seeing these presentations, to go back and feel comfortable about talking to your doctor and creating the team that's going to best help you decide what treatment is best for you.
I just finished 2 years of ADT, Lupron, and abiraterone with radiation at the beginning. How long will it take for testosterone or estrogen to recover? What happens now if my PSA goes up?
That's an excellent question. But again, every person's prostate cancer journey is individual. It's your special journey that you will have. So again, it's best to go back to your team. It's best to go back to your urologist, medical oncologist, and radiation oncologist, because this person here had radiation treatment and continued ADT for 2 years. So that means that a urologist had to be involved, the ADT, the medical oncologist had to be involved, and then the radiation oncologist had to be involved. So it's not beneficial for us to make those calls for you. All we can do is give you the factual information that you can go back and sit down comfortably and talk to your healthcare provider.